So we should move on. You may disconnect, and we'd ask Dr. Jehad to share his screen. Dr. Sami?
Yes, I'd like to welcome Dr. Jehad. He will give us, Dr. Jehad Ahmed is a consultant neurosurgeon and spine surgeon. He's working in Abhan. He had his training in neurosurgery and had Saudi board neurosurgery, and he got a Canadian fellowship in spine surgery in Hamilton. Dr. Jehad will be talking about the vertebral artery anatomy and variation. So welcome, Dr. Jehad. We are looking forward to such a hot topic. You can go ahead, Dr. Jehad.
Dr. Jehad, we cannot hear you. Can you unmute, please?
Yeah, do you hear me now?
Please go ahead.
So I would like to thank the chairman of the 10 Spine Update, Dr. Amr Al-Habib, and the members of the scientific committee for organizing this meeting and for giving me a chance to present. So I will go to describe the vertebral artery anatomy with a special focus in the anatomical variation that we can come across during surgical exposure. So, as we all know, the vertebral artery originated from the posterior superior parts of clavine arteries, although the origin can be variable with brachiocephalic artery on the right side and aortic arch 6% on both sides. The diameter is around 3 millimeters with the mean blood flow 150 ml per minute. Sorry, here. The left vertebral artery is dominant in 60%. The right VA will be hypoplastic in 10%, and the left will be hypoplastic in 5%. Vertebral artery atretic can be atretic. It does not communicate with the basal artery on left side, as we can see in the coming slides. So the course of vertebral artery is basically described in 4 segments, V1 through V4. The V1 originated from, the origin of V1 is the origin of the artery itself through usually C6 transfer foramen, but it can be variable, as we will see later. The V1 segment angles posteriorly between longus colli muscle medially. This is the muscle, and the scalenus muscles laterally behind the common carotid artery to enter the transverse foramen of C6 here. The V1 relations, including anteriorly the common carotid artery, here we just cut it, and thoracic duct, vertebral veins, thoracic duct on the left side and lymphatic ducts on the right side. Posterior to the vertebral artery of V1 of segment of vertebral artery, the ventral rami of C7 and C8, transverse process of C7, as we can see here, and the cervical ganglion. Anteromedially, the inferior thyroid artery, middle cervical ganglion. The V2 segment, and most of this presentation is about V2 and V3 segments because of its surgical importance during our surgical exposure of the cervical spine. It extends from the transverse foramen of C6 up to C2 with a lot of variations. We will come across it later. The V2 segment courses vertically from one transfer foramen to another. It's surrounded by perivertebral venous plexus and includes in periosseal sheath that is continuous with a periosteum of the foramen and transfer process. It is combined by vertebral veins and sympathetic nerves. Now we're gonna go through the variations of V2 segment. I present here 2 studies. The first one in Western population. They studied 500 vertebral artery courses, V2 segment, and they identified abnormal level of entrance into the transfer foramen about 7%. As we can see here, at C3 level, 0.2%, C4 transfer foramen 1%, C5 transfer foramen 5%, and C7 less incidence of 0.8%. And as you can see here, this vertebral artery enters at C4 level, and C5, C6, C7, the vertebral artery the vertebral artery lying freely anterior to the transverse foramen. We did a study in Saudi population. Dr. Amr was the main author in King Saud University Hospital. We collected 50 patients and we studied 100 vertebral artery courses. And as you can see here, sorry, I have just, yeah. So the level of entry into transverse foramen was as follows. On the right side, the level of entry was at C6 with 92% prevalence, followed by 4% at C5 and 2% at both C4 and C7. On the left side, vertebral artery enters mostly on C6, 94%, followed by 4% at C5 and 2% at C4. What is interestingly and well described in literatures is not only the variation between individuals. Actually, within the same individual, there are variation in entrance of vertebral artery into the transverse foramen. As we can see here, this image is from Saudi population. So this is C4 level. The vertebral artery V2 segment on the right side enters as at C4, while on the other side it enters at C6. So special attention for this variation is crucial, because if you are going to do like let's say C5, C6 ACDF, if this anatomy is not well known to you, you might easily injure this segment of the artery, because it's not protected by the transverse foramen. And as I'm going to describe later, this segment, it can form a loop, or it can be tortuous medially. And this is another patient where the vertebral artery enters the transverse foramen of C5 on the left side and C6 on the right side. And the incidence of this variation is 14%, which is quite common. The surgical importance of understanding the V1 and V2 segment variations, because if we fail to recognize the level of entrance, as I said before, it can be very dangerous in anterior or even lateral approach. And the reason because the vertebral artery below the level of entrance is not protected by the transverse foramen, and it can form a tortuous course, which can be easily injured during, for example, ACDF during dissection of longus coli to form the flap. There is interesting variation also, intraosseous variation. We call it the medial loops. This is described in the same study of Western population. So in this case, the foramen this is at C5 level. The foramen is really wide. So the vertebral artery takes a medial loop at the lower level of the foramen before it goes laterally. So this loop, it can come just at the medial edge of longus coli muscle, and it can be easily injured during anterior exposure. V3 segment, and I think this is the most complex segment with the vertebral artery, and it has a complex and mobile course because it allows this mobility within the bone structure, allow the vascular supply preservation during neck movement, especially rotation. It extends from the C2 transverse foramen, goes up in 3 segments to end up piercing the dura to continue as V4. It's described in 3 segments. As you can see here. The first segment is the vertical one, which is start from the transverse foramen of C2 to the transverse foramen of C1, and then the horizontal or transverse segment from C1 transverse foramen till it just taken off from the sulcus arteriosus. So this segment is lying within the sulcus arteriosus of C1. And then the oblique one, which is a continuation from the end of sulcus arteriosus till it enters the dura and becomes intradurally V4. Here, as Dr. Abdul Hadi described very well, that this V segment, especially the horizontal one and the vertical parts, is located within the suboccipital triangle, along with the C1 nerve root and the venous plexus. I will not describe more because Dr. Abdul Hadi already did. And this segment has a lot of anatomical variations and anomalies, and it's very crucial to understand it, whether in normal population or in syndromic cases like Down syndrome, Pierre-Robin syndromes, or Morecus syndromes, or any craniocervical congenital anomalies. I will go through some of these anatomical variations, because to cover it all, I have to spend more time. So the first variation that can come during our exposure for lateral mass screw, and we have to understand it very well, is the extracranial origin of pica, which is quite common. This is one example. The pica comes off the horizontal segment of V3, just at the medial edge of lateral mass. So this one, it can be easily injured or coagulated during exposure, thinking that it is a muscular branch. There is another example here, an angio. This is the vertical segment of V3. It gives us a muscular branch, and the radiculomedullary branch, it continues as pica. So again, coagulating this artery or considering it as a muscular branch, it can end up with posterior fossa stroke. The other variation is apparent suboccipital V3, and this is very crucial and important. And I think when I was with Dr. Abdul Habib, we have seen many of these cases in syndromic congenital craniocervical junction. So we can see here, I will start with this slide, this picture, sorry. This is the occiput, which is fused, this is the C1, which is fused with occipitalized C1. The vertebral artery, it takes a turn under the C1 arch instead of going up, and continues within the spinal canal, and then goes intradurally. So this vertebral artery lies immediately over the entry point of C1 lateral mass screw. Another example here, this is the C1 arch, and under the C1 arch, the vertebral artery is supposed to go this way and come here. It makes a turn under the C1 arch and continues within the spinal canal to end up intracranially. Here is an angio picture. This is the level of C1 arch, and the vertebral artery, this is the vertical segment, and this is the horizontal segment, and this is the oblique. So the whole vertebral artery V3 segments under the C1 arch and then goes intracranially. This is very crucial, and it's quite common in patients with congenital craniocervical anomalies or syndromic cases like Down syndrome, and it needs a special attention while planning the surgery. Another variation of V3 segment is duplication of V3 segment. It means, as we can see here, the V3 has two segments. One of them takes a normal course, and the other one takes an apparent course under the C1 arch. And this one, in this image, number one is the normal. Number three is the abnormal or apparent duplication. So although it's apparent, is the dominant. So this one, it comes again under the C1 arch, posterior to the lateral mass, it can be easily injured. And again, here another example, but in this example, number 1 is the normal, which is the dominant, while number 3, this one, is the apparent. So again, it can be injured, but in first case, injury will be devastating because it's the dominant one, the one taking apparent course. Another example of variations of V3, as we can see here, the V3 can give us to can give into a muscular branch, as we can see here, and these branches, it goes to the muscles, and sometimes, as we described earlier, the pica is a continuation of this one of these branches. So we have to be careful of this. The posterior meningeal artery, as we know, is mainly raised intracranially from V4, but it can come from V3 segment just extracranially at level of C1. This is an example of anatomical variation of V3 in Down syndrome, and we have seen this in practice. In Down syndrome, they have the tendency to have a suboccipital apparent vertebral artery. So as we can see here, the vertebral artery, instead of going into the foramen and then to the sulcus arteriosus, it takes a turn under C1, behind the lateral mass of C1, and then goes intracranially. This one is a fenestration of duplication, as we described earlier. One artery takes the normal course, the other artery takes a suboccipital course under C1 arch behind the lateral mass of C1. Here, a 3D CTA, it showed the apparent course of the V3 segment under the lateral mass. And if we see the CT here, the foramen is very small, and on MRI, the vert is just within the spinal canal. So the vert is here. Another abnormal variation, is the persistent pro-atlantal intersegmental artery. As we can see here, the vert continues and communicate or make anastomosis with either internal or external carotid artery. I left this variation to the end because it's very critical. So the high right vertebral artery. So by definition, the high right vertebral artery is defined as an isthmus of 5 millimeters or internal height of 2 millimeters or less, of course. So the isthmus height is defined as the thinnest part of C2 isthmus, this one, while the internal height of the pedicle is defined as the distance between the outer border of transverse foramen of C2 and the outer part of superior articular process. So if we have a high right vert, we have to be very careful planning our surgical instrumentation for C1 and C2. The incidence is not rare, especially in rheumatoid arthritis patients. In this study, they divide the patient in two groups, those with rheumatoid arthritis versus non-rheumatoid arthritis patient. A patient with rheumatoid arthritis, they have a very high incidence, up to 42 or 50%. The average is 20%. As we can see here in a CT, the transverse foramen is really wide. The distance of the internal height is small, and the isthmus is also short. And on the axial, you can see a very wide transverse foramen. Understanding this anatomy is crucial because if we identify the high right vertebral artery, then most likely we will not do C1, C2 transarticular fixation. Most likely you will skip C2 pedicle screw, and sometimes even C2 pars. So we'll go to laminar screws or just skip it and go to C3. This is a rare variation or anomaly, which we call it arcuate foramen, where the atlanto-occipital ligament ossified and form a foramen here, through which the vertebral artery passes at the level of sulcus arteriosus. V4 segments, which is the intradural one, as we can see here, this is the one, is a continuation of V3 anterior to the accessory and ascending spinal accessory nerves and hypoglossal nerves. It joins with the other side to form the basilar artery, and it gives, in most of the population, it gives to the branches of vertebral artery, including anterior spinal, pica, and posterior meningeal artery. But again, there are variations where these arteries can arise from V3. So the home message here is craniocervical fusion must be, actually it's not only craniocervical fusion. I would say anterior and posterior cervical exposure and surgery must be preceded by examination of vertebral arteries at the level of C2, looking specifically for high right vertebral arteries, because if it is present, then we have to change our surgical plan, like avoiding transarticular transpectoral screws. Careful analysis for preoperative MRI, contrast CTA to detect any vertebral artery anomalies and avoid serious complications that could occur because of VA injury. Special attention has to be given for craniocervical anomalies and syndromal cases where this variation in vertebral artery, and more specifically in V3 segment, is more common, like in Down syndrome, Rickets syndrome, and Pierre-Robin syndrome, and occipitalization of C1. I try my best to make it as short as I can. Thank you so much. I'm open for any questions or comment.